now going to start with heart failure, and it's a great pleasure for me to introduce Professor Theresa McDonagh, who's Professor of Cardiology at King's College Hospital. And I've heard Theresa talk many times before, and you're going to be in for a treat. It's putting pressure on you, Theresa. And she's going to talk about the exciting times we have now in heart failure therapy.
So, thank you very much, Derek, for the invitation to speak once again, and for the opportunity to lower the tone of your meeting from the elegant science to the mundane subject of the treatment of heart failure. These are my declarations of interest, I think two of which are relevant to the talk that I'm going to be giving. So I'm going to really concentrate on new and newish therapies for heart failure. You'll be relieved to know that I'm not going to talk about the entire spectrum of heart failure or be here all day, but concentrate on the newest developments for the treatment of chronic heart failure and three subtypes within that, a treatment of one important comorbidity. I'm not going to touch on acute heart failure, because unfortunately we have no new treatments in that realm of heart failure really for the last 20 years, which is a bit disappointing. But anyway, the rest of it makes up for it. So just to remind ourselves about the syndrome that we're talking about treating here, heart failure, of course, is a clinical syndrome, a constellation of symptoms and signs that are ultimately due to cardiac dysfunction. And just to be very simplistic, I've kind of divided the chronic heart failure world here into sheep and goats that we're going to be talking about today, mainly concentrating on the panel on the right there, heart failure with reduced ejection fraction, where there's impaired systolic function, usually a dilated heart with a poor left ventricular ejection fraction. And then on the left-hand side, from my point of view, the other more Cinderella type of heart failure that we've called heart failure with preserved ejection fraction. Usually the longitudinal systolic function is normal, the ejection fraction is normal or preserved, but there have to be other structural or cardiac structural and functional abnormalities, most commonly left ventricular hypertrophy with impaired relaxation of the ventricle. Well, I've been very simplistic there about the two types of heart failure I'm going to talk about. It's a little bit more complicated, or has become a little bit more complicated in recent years by really changes in definition of heart failure with preserved ejection fraction, which used to start with a cut point of an ejection fraction above 40%, and over time that's crept up to 50%, which leaves us with a middle child that in the most recent ESC guidelines, we've named heart failure with mildly reduced ejection fraction. So in terms of mildly reduced ejection fraction, in terms of epidemiological data and response to therapies, it behaves much like heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction, you have to have a significant impairment in your left ventricular systolic function, an ejection fraction of less than or equal to 40%. The treatments for heart failure with reduced ejection fraction also work in mildly reduced ejection fraction heart failure, but maybe just not to the same degree. So I'm going to start with heart failure with reduced ejection fraction itself, and of course the newish evidence we have here, starting in 2019, is for a new class of therapies, sodium glucose cotransport inhibitors, of course originally developed for diabetes, but then trialed in heart failure. And we have two studies now in heart failure with reduced ejection fraction in patients with and without type 2 diabetes. We have the DAPA-HF study with dapagliflozin showing a reduction in cardiovascular deaths and hospitalizations for heart failure. And then it was followed up a year later by the EMPEROR reduced trial, empagliflozin in patients with HFrEF, again a reduction in a composite endpoint of cardiovascular deaths and hospitalizations for heart failure. So, SGLT2 inhibitors really join our class 1A evidence-based therapies for heart failure, treatments which are recommended to reduce cardiovascular death and hospitalizations for heart failure. They obviously join essentially 3 other groups of therapies that are recommended in patients with HFrEF: angiotensin-converting enzyme inhibitors, beta blockers, and the mineralocorticoid receptor antagonists, spironolactone and eplerenone. All of these drugs reduce cardiovascular deaths, hospitalizations for heart failure, all-cause mortality, and they improve quality of life in patients with heart failure. So SGLT2 inhibitors have joined that group. There is another drug class in there, of course, sacubitril valsartan, a combination of an angiotensin receptor blocker, valsartan, with the neprilysin inhibitor sacubitril, which stops the breakdown of the natriuretic peptide hormones, good guys in heart failure. It also has class 1 evidence. But in the European guideline, it's still recommended as a switch from an ACE inhibitor, because in the Paradigm study, patients who were already on a good dose of enalapril were actually switched to sacubitril valsartan, and it did have a better outcome than enalapril. But it's only one trial, so we're still recommending it after you've tried the patient on an ACE inhibitor. Now, not all people would agree with me in taking that view. There are small studies out there which have looked at using sacubitril valsartan in patients with heart failure, in patients who are ACE inhibitor naive. And this is a study done in the US a few years ago, randomizing patients in an open label manner to sacubitril valsartan or enalapril. The primary endpoint was a surrogate one, a reduction in NT-proBNP, and sacubitril valsartan did that more effectively than enalapril. And when they looked in a post hoc analysis, those assigned to sacubitril valsartan did seem to have a reduction in cardiovascular deaths and hospitalizations for heart failure out to 6 months. So it's certainly something you can start instead of an ACE inhibitor. But the class of evidence we gave it in the ESC guidelines would be that's something you may consider rather than something which is recommended de novo. So just to go away from now standard neurohormonal blockade of the renin-angiotensin-aldosterone system or sympathetic nervous system, to turn to some new agents that are out there and are now appearing in guidelines. We're not really using them yet, but they may have potential in the future. Starting with vericiguat, which is a soluble guanate cyclase stimulator. So essentially a drug that increases cyclic GMP, so promotes vasodilatation in heart failure. It's been looked at in patients with reduced ejection fraction heart failure on the severer end of the spectrum, people remaining symptomatic on optimal medical therapy. And you can see it has a modest effect. There is a 10% reduction in cardiovascular deaths or hospitalizations for heart failure, and that main effect is on hospitalizations. So this is something we may consider in the future if patients remain symptomatic despite ACE, beta blocker, MRA, and SGLT2 inhibitors. There's also the emergence of the first oral inotrope in heart failure, I suppose, other than digoxin, omecamtiv mecarbil, which is a cardiac myosin activator and can be taken orally. It was looked at in the Galactic HF trial, again in a large number of patients who remain symptomatic despite optimal medical therapy for reduced ejection fraction heart failure. And you can see once again here, very similar to vericiguat, there's a modest effect. There's an 8% relative reduction in cardiovascular deaths or hospitalizations for heart failure. So again, something that we might be able to add in the future for patients who are struggling. So in terms of where we've got with the new therapy, this is, I think, what our therapeutic algorithm for treatment of patients with reduced ejection fraction heart failure looks like, or looked like in 2021, and I don't think has changed since. So you'll see in the top with the green box, a change to previous algorithms where we had all these drugs in separate boxes before, sequentially adding one after the other. We've put them all now in one box, an ACE inhibitor or sacubitril valsartan, beta blocker, an MRA, an SGLT2 inhibitor, as all class 1 recommended therapies. Loop diuretics also make it in there, not because we have much clinical trial evidence for improvement in outcomes, but because they do improve symptoms in patients with heart failure and reduce hospitalizations. Then, of course, there are other decisions to be made that I can't really talk about today for time, about device therapy based on ejection fraction and QRS duration, with the implantation particularly of defibrillators and cardiac resynchronization therapy pacing. And then after these class 1 or 2A recommendations, considering drugs which may help if the patient remains symptomatic, and in that category, of course, would be the old favourites, digoxin, hydralazine nitrate, as well as the newcomers, vericiguat and omecamtiv. So moving away from new drugs now to what this has done in terms of new concepts of treating patients with heart failure with reduced ejection fraction, which is obviously something that vexes us clinicians who have to start and up-titrate these drugs. So in the past, we tended to use conventional sequencing of these drugs, essentially following the order of addition that we found in the clinical trials, which of course started in the late 1980s with enalapril and going up to the current day. So we tended to add an ACE inhibitor, up-titrate it, add a beta blocker, up-titrate it, add a mineralocorticoid receptor antagonist. Mercifully, they don't need much up-titration. Then, if your patient was still symptomatic, switch the ACE inhibitor to sacubitril valsartan, and then most recently add the SGLT2 inhibitor. Scientifically, very pleasing, but obviously the whole process can take some considerable time. Measuring blood pressure, renal function, it can take you about 6 months to get to optimal doses of drug therapy using this sequence. So is there a reason maybe to change this and think about doing things more quickly, that we've put all these drugs into one green box? Well, I think there is reasonable evidence to back that up, and sequencing in the clinical trials is actually not very evidence-based. Many patients in the clinical trials were not on an optimal dose of the previous drug before they looked at the interventional drug. I suppose if we took this to extremes, everybody should be on digoxin, because the very early ACE inhibitor and beta blocker trials, nearly everyone was on digoxin. And the problem is that the effects of these key drugs actually become evident within weeks of starting at low doses. So we have to take that into account. And perhaps more importantly, the efficacy of the drugs we're using is actually independent of the other drugs that the patients are on. Unfortunately, the side effects are not independent of each other. So I think there is a body of evidence that is suggesting, retrospectively looking back into the clinical trials, that early initiation of all these 4 drugs will save lives. So we have to think about ways of doing that. Now, various people have come up with various novel ways of up-titrating these drugs. This is just one I've picked out from the literature by John McMurray and Milton Packer, which has suggested we maybe start with the beta blocker, which of course can reduce sudden cardiac death, and then add the SGLT2 inhibitor, which has got a mild diuretic effect, and then consider the ACE inhibitor or sacubitril valsartan, which are going to cause more problems with hypotension, renal dysfunction and hyperkalemia, and then lastly add the mineralocorticoid receptor antagonist. And in terms of the 3 steps they suggest, you can get everybody onto one of these all 4 of these drugs within 4 weeks, and then up-titrate. And there have been there are various other complicated titration regimes out there. I don't really favour this very much. I would suggest here that we use our clinical acumen and be pragmatic. Firstly, because actually most chronic heart failure patients do not appear out of thin air on no therapy. Most of them appear from the land of ischemic heart disease, diabetes, hypertension, and many of them are on ACE inhibitors, mineralocorticoid receptor antagonists, beta blockers anyway. So in that case, you just have to, of course, add the missing ones. For therapy-naive patients, really true de novo heart failure patients, I think use your clinical judgment. So aim to get everybody on all 4 drugs by 1 month and then up titrate. But if at the outset chronic kidney disease or hyperkalemia is an issue, then start with the beta blocker and the SGLT2 inhibitor, and then get into the ARNI or ACE, and lastly the MRA. If systolic blood pressure is your problem, you might want to start with the SGLT2 inhibitor, the beta blocker, and the MRA because they lower blood pressure less, and then go to the more hypotensive ACE inhibitors and ARNIs. And of course, if heart rate's your issue, then you might want to prioritize the ACE, ARNI, MRA, and SGLT2 inhibitor before you think about the beta blocker. I would remember always to stop unnecessary drugs that have got into the patient's dosette box or drug cupboard that lower blood pressure. Legacy drugs like amlodipine, nitrates, stop these to improve blood pressure, and remember to try and also stop other drugs which may affect renal function. But I think the new message is go as quickly as possible and not as slowly and cautiously as we have done in the past. Why? Because if we look back at meta-analyses that are now coming out of the drug trials in chronic heart failure over the last 30 years, it's very, very evident that being on 4 drugs, and here if you're being on the best drugs, the ARNI, the beta blocker, the MRA, and the SGLT2 inhibitor, if you take an average patient of 70 years, you will extend their life by 5 years by having them on all of these 4 drugs versus being on no drugs at all. And you can see the effects of being on 3 drugs or 2 drugs decrementally get worse. So try to do it a bit more quickly. I'm now going to turn to the more Cinderella end of the spectrum, those patients who have heart failure in the presence of a preserved left ventricular ejection fraction. Now this, as you know, has been a rather fruitless area in the last 20 years of searching for treatments, because if we look at large randomized trials with the usual suspects that worked in reduced ejection fraction heart failure, in this case ARBs, spironolactone, and indeed sacubitril valsartan, all of these trials were neutral. There was no effect on reduction in all-cause mortality, cardiovascular deaths, and even hospitalizations for heart failure, which was very, very disappointing. And at the time we wrote the ESC guideline just over a year ago, we ended up with this rather poor set of recommendations for treating these patients, screening for the underlying cardiovascular conditions that cause heart failure, and diuretics to relieve congestion. On the same day we presented our guideline, there was, however, some good news in that the Emperor preserved trial reported with the SGLT2 inhibitor empagliflozin in patients with heart failure with preserved ejection fraction. When I say preserved here, I mean patients with ejection fractions above 40% as well as above 50%, so mildly reduced and preserved ejection fraction heart failure, with at last a positive primary endpoint reduction of 21% in cardiovascular deaths and hospitalizations for heart failure, with the principal effect being on reduction in hospitalizations. And then, like London buses, they started to come along a bit more frequently, and This summer we had the second trial with an SGLT2 inhibitor, this time dapagliflozin, again in patients with ejection fractions above 40%, a very similar result, an 18% reduction in cardiovascular deaths or worsening heart failure, with no independent effect on cardiovascular deaths, a reduction in hospitalizations. And as is the case in heart failure trials, once you get 1 or 2 or 3 or 4, you start doing meta-analyses, and we're now seeing meta-analyses for preserved ejection fraction trials. And if you put DELIVER and EMPEROR preserved together, and this is an aggregate patient data meta-analysis, you can see overall about a 20% reduction in cardiovascular deaths or hospitalizations for heart failure, and also just about a significant reduction in cardiovascular deaths themselves when you put these two very large trials of nearly 10,000 patients together. So we're getting there now. I can't show you ESC guidelines because our update for preserved ejection fraction heart failure is actually going to be presented at the ESC coming meeting in Amsterdam, but the Americans did manage to update their guideline last April. So for patients with preserved ejection fraction heart failure, they've got a 2 indication for SGLT2 inhibitors, drugs we should consider. I would assume now we've got 2 trials that in the future guidelines will be recommending SGLT2 inhibitors as a 1A indication for heart failure with preserved ejection fraction. So that then takes us back to the middle child, squashed between these 2 well evidence-based zones. We have obviously no specific trials with patients with ejection fractions between 40 and 50% to rely on. So we are really looking at subgroup analysis of HFpEF trials that were essentially neutral. But when you look here at this group of patients whose ejection fractions are between 40 and 50%, essentially ACE inhibitors, ARBs, beta blockers, MRAs, and sacubitril valsartan do seem to reduce cardiovascular deaths and hospitalizations for heart failure, albeit just to a lesser degree than in patients with HFrEF. And of course, we have from the 2 SGLT2 inhibitor trials in patients with ejection fractions above 40%, these drugs are going to be recommended in patients with heart failure with mildly reduced ejection fraction. So I'm going to just finish in the last 5 minutes, just turning to what I think is becoming maybe a bigger problem for patients with heart failure as they age and the prevalence of heart failure increases. The age presentation is creeping up and up. In this study, epidemiological study from Oxford, from Kazi and Rahimi's group, it's now mean age of 77 years at first presentation of heart failure. In the National Heart Failure Audit for hospitalized patients, it's 80 years. They're older, they're frailer, and the number of comorbidities they have at presentation is now really quite concerning. At least 5 comorbidities. They're listed here on the right, and they are by no means insignificant. A quarter with anemia, a quarter with cancer, nearly half with atrial fibrillation, a quarter with chronic obstructive pulmonary disease, up to a third with diabetes, things that themselves impair quality of life and worsen outcomes in heart failure. So I think a lot of heart failure effort in the next few years is going to be looking at ways of treating comorbidities in patients with the heart failure syndrome. I'm just going to focus on one where there has been some success, and that's iron deficiency. And I'm talking about here about iron deficiency irrespective of the presence of anemia. So in chronic heart failure, about 40% of patients are iron deficient if we measure a ferritin less than 100, or if their ferritin is between 100 and 300, TSATs of less than 20%. About 40, maybe up to 50% of patients are iron deficient. And we know that replacing iron with intravenous iron, and in particular with ferric carboxymaltose, in a number of small trials, has shown that patients improve their effort capacity and quality of life with intravenous iron. This is the FAIR-HF study which first showed that, and there was another small study, CONFIRM-HF, again with ferric carboxymaltose, that confirmed those results, treating patients out to about 6 months. We now are seeing harder outcome trials with intravenous iron, and this was the first to report in 2020, the AFFIRM-AHF trial, which looked at intravenous iron with ferric carboxymaltose in patients with reduced ejection fraction heart failure who were hospitalized for heart failure and were iron deficient. It just failed to meet its primary endpoint. There was a trend towards reduction in heart failure hospitalizations and cardiovascular deaths, but this trial took place during COVID, and if you look at the COVID sensitivity analysis, there does seem to be a significant effect in terms of reduction in hospitalizations for heart failure. It's been followed up by a trial that's just reported a couple of weeks ago now at the American Heart Association, Ironman, which was a trial done in the UK in 80 centres, looking at patients with chronic heart failure, with reduced ejection fraction heart failure and iron deficiency. Again, it was a COVID study. The formulation used here was intravenous ferric dirysomaltose rather than ferric carboxymaltose, and you can see here an almost, again, a trend towards reduction in cardiovascular deaths or hospitalizations for heart failure. And if you look at the COVID sensitivity analysis, it did hit its primary endpoint. Again, a reduction in hospitalizations for heart failure. So, good news, particularly in terms for SGLT2 inhibitors, intravenous iron. We've still got a way to go. There is still a residual cardiovascular death hospitalization rate for patients with HFrEF of about 20%, that's perhaps modifiable, and maybe up to 40-50% for HFpEF, and of course we haven't yet got anywhere with acute heart failure, so the job's not done. There are many new trials with new agents ongoing, and I think we are going to hear some more information for HFpEF hopefully this year with the non-steroidal mineralocorticoid receptor antagonist finerenone. So it's a bit like spironolactone and eplerenone, but doesn't give you the same amounts of hyperkalemia, chronic kidney disease. More trials with intravenous iron in heart failure with preserved ejection fraction, treatments that look at hyperkalemia, which often limits our up-titration of especially renin-angiotensin system blockers. And of course, we've also had new treatments for amyloid, an important cause of heart failure in the elderly, particularly tafamidis. And we've got more treatments which are going to present this year with small molecule therapies in Theresa and patisiran. So much more coming, but it's certainly good news, and it's certainly been exciting in the last 2 years. So I'll stop there. Thank you.